Welcome. In this lecture, we'll be discussing thrombotic thrombocytopenic purpura, HUS, and DIC. Let's first cover the pathology of TTP. This centers around a deficiency or inhibition of something known as the ADAMTS13 enzyme. To understand the pathology, let's first talk about the normal function of this enzyme. Normally, ADAMTS13 is a metalloprotease enzyme responsible for cleaving large multimers of von Willebrand factor. This is cleaved into smaller, less active forms. Von Willebrand factor mediates platelet adhesion during vascular injury. Thus, cleavage of the VWF multimers prevents excessive platelet aggregation and thrombus formation. Thus, when ADAMTS13 enzyme is present, we do not have platelet aggregation and we do not form thrombus. A deficiency leads to these large von Willebrand factor multimers. The pathology consists of either an autoimmune inhibition, like the ADAMTS13, or can sometimes be caused by genetic mutations. This deficiency in ADAMTS13 leads to accumulation of these ultra-large von Willebrand factor multimers. Without ADAMTS13, these multimers persist in circulation. This can lead to spontaneous platelet aggregation as seen in this diagram. This aggregation typically consists in high shear areas, such as capillaries or arterioles. This forms platelet-rich microthrombi, which will lead to a large multitude of the symptoms and lab values that we will see in this disease, such as thrombocytopenia, MAHA, also known as microangiopathic hemolytic anemia, and organ ischemia. So understand that this deficiency in this enzyme leads to these formations of these microthrombi. This thrombosis causes a multitude of the symptoms. Now, what symptoms are we talking about exactly? TTP has a clinical pentad remembered by the mnemonic FAT-RN, where F stands for fever, A stands for anemia, specifically microangiopathic hemolytic anemia, also known as MAHA, and thrombocytopenia is the T, renal damage neurologic is the N. This is typically seen in adults. It is important to know that you only require MAHA and thrombocytopenia for diagnosis. Both the hemolytic anemia and thrombocytopenia occur due to that platelet formation of those microthrombi that we talked about in the previous slide. These platelets are consumed to make these thromboses, and the hemoglobin is destroyed as it travels now through these narrow blood vessels with the thrombi. Some symptoms that you want to be on the lookout in question stems that can demonstrate thrombocytopenia will be epistaxis or bloody nose and easy bleeding. Renal damage is typically going to be demonstrated by AKI or increased creatinine. Neurologic symptoms can be anywhere from headaches to altered mental status to even seizures. But you're looking for this pentad on test day. But it's important to know that these two are the only two required to diagnose this disease. Lab values can also be utilized to help suggest TTP. What we're going to see in these lab values are going to be lab values that demonstrate MAHA and lab values that demonstrate thrombocytopenia. MAHA, you typically see an increase in LDH. LDH, also known as lactate dehydrogenase, is an enzyme found inside red blood cells. When the red blood cells rupture, LDH is released in the bloodstream. Because we have hemolytic anemia, this leads to rupture of those red blood cells, which leads to an increase in LDH. You also see low haptoglobin. Haptoglobin binds to free hemoglobin when it's released from destroyed red blood cells. In intravascular hemolysis, such as what we see in TTP, the free hemoglobin levels increase, which causes haptoglobin to bind to it. Thus, we expect to see a low haptoglobin. And you will also sometimes see schistocytes. Schistocytes, how I like to remember it, is similar to Shearocytes. This is an image of what schistocytes look like. you can see that they are literally just sheared red blood cells, little fragments of what red blood cells are. And this is due to them shearing as they go through that vasculature of those capillaries due to the thrombi formation. Thus, we typically see an increased LDH, low haptoglobin, and sometimes these schistocytes. You can also see thrombocytopenia. This will either be a low platelet value, less than 100,000, sometimes 120,000, or can be demonstrated with an increase in bleeding time. Since the issue is actually due to a lack of platelets, we will have an increase in bleeding time. Of note, because this does not factor in our coagulation cascade or our factors, factor 7, factor 8, etc., PTT is typically normal, and Coombs is negative in thrombocytopenic purpura. Now, how exactly do we treat these individuals? Treatment is going to be typically plasma exchange. This is the cornerstone of TTP treatment. The idea here is that this removes the autoantibodies against that ADAM-TS13, and it can also provide functional ADAM-TS13 enzyme from donor plasma. It is important that we do not wait for confirmation. Plasma exchange is started immediately upon suspicion of TTP. We do not wait for lab confirmation. That is something that is high yield and something that you want to know for your exam day. We can also use either steroids or rituximab. Steroids, such as methylprednisolone or prednisone, will be started with plasma exchange. The idea with steroids is to reduce inflammation and autoantibody production. Rituximab, the MAB, stands for monoclonal antibody. This is a monoclonal antibody against CD20. This is typically used in refractory cases, relapse, or similar to steroids as an early add-on therapy. Rituximab targets the B cells producing the anti-ADAM-TS13 antibodies and destroys them. We typically more so use steroids on exam questions, but be aware that both are typically used in real practice. For refractory cases, we can typically undergo splenectomy. This is only when they do not respond to the above. It is also high yield to understand that platelet transfusions are contraindicated in TTP, as this will actually worsen the disease, worsen those fat RN symptoms by feeding the platelet consumption. But the big takeaway is to understand that plasma exchange is the gold standard for TTP treatment. TTP is typically compared to something known as Hemolytic Uremic Syndrome. The pathology here is different than TTP. This is typically caused by a sugar-producing E. coli, such as O157H7, which causes the sugar toxin to bind to receptors. This causes direct endothelial cell damage and inflammatory response. These damaged cells, or these damaged endothelium, exposes these prothrombotic surfaces. This triggers platelet activation and aggregation, causing microthrombi. Thus, in HUS, we are still producing these microthrombi, which like to affect renal, in this case, capillaries and arterioles. Very similar to TTP, we're not producing autoantibodies. This is due to a sugar-like toxin typically. The symptoms are going to be very similar to TTP. We typically see a triad instead of a pentad. Again, we're going to have that thrombocytopenia and MAHA, which we see in TTP. This is due to this microthrombi production, which leads to those shearing and destruction again. But since this HUS typically prefers the renal capillaries and arterioles, we can also see renal damage. We typically do not see fever or neurologic symptoms. You can in real clinical practice, but typically differs on exam questions. These individuals will typically have a history of a recent GI bug. Look for bloody diarrhea. Bloody diarrhea in a person who presents with this triad suggests exposure to E. coli. Remember, although E. coli is the most common cause, it can also be caused by Shigella or even strep pneumonia are also common causes of HUS. And unlike TTP, this disease is more so seen in children. Now, for completeness sake, I've included the labs here. Just note that these labs are going to be the same as TTP. This is again caused by that microthrombi production. The treatment, on the other hand, is a little bit different. The treatment in this case, because we are not producing autoantibodies, is typically going to be more so supportive. such as IV fluids and electrolyte repletion. In some cases, we can give dialysis, but that is only if the AKI, or that increase in creatinine, does not respond to fluids. The big takeaway here is that this is going to be supportive treatment. We typically let this infection, E. coli, sugar-like toxin, run its course, where in TTP, since we're producing these autoantibodies, we typically are going to treat this with steroids. For severe cases, we can do that plasma exchange, but generally, this is only for extremely severe cases. The big takeaway from HUS comparatively to TTP is the pathology, how it produces something similar as in microthrombi, but it does it via a different mechanism, this sugar-like toxin, and of course, the treatment. Look for these symptoms which differ from TTP on test day. Both HUS and TTP can be compared to something known as disseminated intravascular coagulation. DIC is a condition where the body's clotting system becomes overactive in response to a trigger like infection, trauma, or even cancer. This leads to widespread clot formation in small blood vessels, and this clot formation uses up platelets and clotting factors. As a result, the body runs out of the materials needed to clot properly, causing both clotting and bleeding at the same time. Thus, we're going to see both bleeding and clotting here, and this is always triggered by some sort of underlying cause. The symptoms here are typically going to be very classic. You will see bleeding/oozing at catheter sites or mucosal surfaces. Whether this is central lines, PICC lines, peripheral IVs, look for oozing at all of these sites, even urinary catheters. You may see something known as purpura fulminans. This is a rare life-threatening condition characterized by sudden, widespread skin bleeding and necrosis that we can see here. This is due to severe clotting in these small blood vessels, typically seen in DIC. So if you see someone coming in there bleeding at all cell lines, and they're having these necrotic-like skin lesions, always think of DIC. Petechiae, which are typically seen in thrombocytopenia, hypotension, ultimate tachycardia, due to this widespread bleeding and formation of clots, you can form all these symptoms. But definitely look for these two things on test day, which are going to scream DIC. What labs exactly do we see in DIC? Typically, the issue is going to be everything is affected. Remember, with TTP and HUS, we typically only see MAHA and thrombocytopenia, only affect bleeding time. This is a lack of factors, coagulation factors. Thus, we're going to see a decrease in platelet count, as we know. That is due to the platelet consumption, remember, forming those thrombi. That's a common theme in this lecture, which is seen in TTP, HUS, and DIC. Fibrinogen will be low, as this is typically used up to form these clots. PT and PTT are going to be increased because we no longer have factors. We run out of factors from producing in our liver. Thus, this leads to elongation of the PT and PTT. D-dimer should also be elevated due to the breakdown of fibrin. And in our peripheral smear, similar to what we see in TTP and even HUS, you can see schistocytes. The big takeaway is that everything is affected, not just platelets, not just hemoglobin. It will be affecting your coagulation cascade now. The diagnosis of DIC is based on these clinical lab values as well as symptoms. So how exactly do we treat DIC? DIC typically has three mainstays of treatment. Remember, DIC is caused by some sort of underlying disease, such as cancer or some sort of infection. Thus, we're going to treat the underlying condition, whatever that is. The hallmark for DIC is either going to be fresh frozen plasma or cryoprecipitate. Fresh frozen plasma is used as DIC consumes many of those clotting factors like 5, 8, fibrinogen. This leads to bleeding. Fresh frozen plasma contains all clotting factors, so it is given to replenish depleted factors, help to stop the bleeding, and of course to correct PT and PTT. Thus, we give this when an individual is bleeding or when they have prolonged PT-PTT in someone with active DIC. The other one that we're going to be treating with is cryoprecipitate. Cryoprecipitate is rich in specific factors, not all factors like fresh frozen plasma. These factors consist of 8, 13, von Willebrand factor, and of course fibrinogen. Fibrinogen is the big one. In DIC, fibrinogen levels usually drop, typically to less than 100. When this happens, this low fibrinogen makes it hard to form stable clots. This can worsen bleeding. Thus, we typically give cryoprecipitate when the fibrinogen levels is less than 100. They should not make you choose between these on test day, but just in case they do, I've included when we give each of these. But both of these are the hallmark of DIC treatment, fresh frozen plasma and cryoprecipitate. The rest is going to be supportive. IV fluids, potentially heparin. Heparin is obviously related to how the platelet level is. But the big thing I want to take away from the supportive portion is that in DIC, we can transfuse platelets. Remember, with TTP, they are contraindicated. That is not the case in DIC. The big takeaway from this slide is we treat the underlying condition and we typically can give fresh frozen plasma or cryoprecipitate. I've created a summary slide comparing 4 diseases. I have included ITP, which was covered in another lecture. Please note that as we move more to the right here, more things become more positive. DIC, as we can see here, is going to be everything is positive, aka everything is abnormal. But this is for your studying purposes as a quick summary slide comparing these 4 diseases. And that concludes this lecture on TTP, HUS, and DIC.